Alright, hey guys. Okay, so we're going to talk about hepatitis, and we are continuing on in chapter 47, our GI studies. So let me get this going. Alright, so hepatitis. We have acute and chronic, and it's inflammation of the liver. A lot of times, most commonly, it is going to be a viral. It can be caused by toxins, different chemicals, drug-induced, or it can be autoimmune. So the viral is a systemic infection that results in necrosis and inflammation of the liver cells. Viral is really easy to transmit and it causes a high morbidity. The liver can become inflamed shortly after exposure to toxic drugs or chemicals or after chronic alcohol abuse or infections. Hepatitis comes in several different forms. You have A, B, C, D, E, and you even have a G, which is transmitted through blood, but we don't talk much about that one. Each type has different mode of transmission and incubation periods, and you can see a great chart in your book on page 784, table 47.3, that kind of lays all of them out and really makes more sense, I guess. There are different phases, and so with the phases you can see that it starts with incubation phase. And so this is where the virus replicates with the liver. It can be found in the blood, the bile, and the stools, so they are able to actually test it and see that the virus is there. The patient is usually going to be asymptomatic, but considered infectious during this period of time. Pre-icterate or prodromal phase, this is where you're going to start seeing that they have some symptoms. They're showing some symptoms. So they'll have some nausea, some vomiting, right upper quadrant discomfort, enlargement of the spleen, liver, lymph nodes, weight loss, rash, and even some urticaria. In the icterate phase, you're going to see jaundice, pruritus, that itching of the skin, clay-colored stool, dark urine, fatigue, anorexia, and pain. And you could even see some of those pre-icterate signs and symptoms as well in this one. And then post-icterate phase, you're going to see that the liver is enlarged. They'll have a lot of malaise, fatigue, and their liver enzymes are actually going to return back to normal. Hepatitis A. So hepatitis A, the mode of contraction is going to be oral fecal. So a lot of times this is poor sanitation, not washing hands. You can see the lovely water coming out of the sink right there. Feces and saliva of infected persons, water, food, something like that. And exposure may occur in areas of poor sanitation. So some of those third world countries that don't really have good clean source of water, this is where you could contract hepatitis A. The signs and symptoms are going to be flu-like or asymptomatic, and prognosis with this one is very good actually. We can prevent it with a vaccination, so that is a possibility as well. Hepatitis B, we do have a vaccination for this one as well. Hep B, HBV. The mode is going to be blood, vaginal secretions, and semen of infected persons. There are contaminated needles, equipment, sharing needles, drug users, not safe sex. That's kind of how you would contract this one. Signs and symptoms will be like arthritis presentations, rash, lesions, and they might be asymptomatic. Prognosis is going to be more severe. It could cause possible liver cancer or even failure. And again, we can prevent this one with a vaccine. This is the first vaccine that we actually give newborns in the hospital, Hep B. Hepatitis C, HCV, the mode is going to be blood, sexual contact, saliva, and IV use. So you can kind of see a picture right here of those things. IV drug use is going to be the most common. And then needle sticks. If you have a patient who is positive for Hep C, and you end up sticking them and then sticking yourself with a needle, you could contract it that way as well. It is similar to Hep B, although it's less severe. And the prognosis is increased risk of liver cancer. Hepatitis D and E. Hepatitis D, same mode as Hep B, but you cannot be infected alone with Hep D. It occurs with an infection of Hep B. And hepatitis E is going to be fecal-oral mode of transportation, and it has a low risk of personal contact. With the different hepatitises, for diagnostics, we're going to do a serological testing to detect any of these viral antibiotics. Ribonucleic acid, the RNA, white blood cell counts will be elevated. ALTs, ASTs will also be elevated. You'll often see a prolonged PT or PTT, which puts them at risk for bleeding. Liver biopsy for a definite diagnosis. With hepatitis, any of the hepatitises, there is treatment and prevention. We're going to teach and practice good hygiene, universal precautions, limit protein consumption. We don't want them to be drinking alcohol or using illicit drugs. Their liver is inflamed and it is damaged, so that only complicates this disease even more. Encourage them to rest, balanced diet with small meals, supplemental vitamins. Because they're not able to absorb those vitamins, their liver is damaged, so we need to be supplementing some vitamins. Vaccinations are available for A and B, but not all of the hepatitises. Chronic B, C, and D may need antiviral meds to force them into remission. And you guys, y'all can look all this up and see that on 786 as well. Just talking about the different antiviral meds that we might use to force that into remission. And then those that don't respond to medical treatment may need a transplant. Of course, anytime you have liver disease, it's kind of hard to get a transplant. Hepatitis, again, teaching, we want to teach them how to avoid the disease and how to stop the spread. Use safe sex or abstinence. Don't share any kind of razors, toothbrushes, nail clippers, needles. There is a slight risk involved with needles, so if you're one to get a bunch of tattoos, know that you are taking a risk there. Don't drink the water, wash your hands, and just say no to drugs. Gallbladder diseases. So the gallbladder stores and concentrates bile. It comes down, it's kind of right below the liver. Cholelithiasis or calculi, stones in the gallbladder or duct system. And then cholecystitis is an inflammation or infection of the gallbladder. You're typically going to see these two together. So if you have calculi and stones in the gallbladder, you're usually going to have inflammation as well. So these two disorders go hand in hand. The patho is simply cholelithiasis and cholecystitis almost always exist together, coexist. The cause unestablished, most likely from bile stasis, dietary factors, and infection. And with the dietary factors, typically you see this inflammation come on after a real high-fat diet food. So here's just kind of a picture of what's going on here. And you can see these stones right here. This stone is going to be blocking that into the intestine as well as the pancreatic duct. Symptoms tend to appear after consuming fatty foods. A hormone is excreted by the small intestine that stimulates the gallbladder to send bile for digestion. Gallbladder forcefully contracts, and discomfort results from the inflammation in the spasm. So it's trying to send down that bile to help digest, the food. However, since it's blocked, it causes kind of spasms and it's not able to get through the way it needs to. Nausea, vomiting, flatulence, belching, right upper quadrant pain, and we actually call this biliary colic, and it typically will radiate to the back and the shoulders. There will be tenderness over the liver, itchy skin, that pruritus. You may have fever, jaundice, dark urine, and clay-colored stool because that bile is not getting absorbed the way it needs to. The treatment for cholecystitis or cholelithiasis, if it's acute, it'll just be NPO. We're going to keep them without food or drinks. We'll drop an NG tube down, we'll use some antibiotics, pain relief, and IV fluids until the inflammation subsides. If it's mild or chronic though, we're going to put them on a low-fat diet, we're going to encourage them to rest and offer pain relief, weight reduction when it's indicated, and there is an extracorporeal shockwave lithotripsy or ESWL that we can do, and that's actually going in and shock waving those stones and breaking them up that way. Cholesterol binds to the bile salts, so this will relieve that pruritus that they sometimes feel. They can do a lap chole or an open cholecystectomy and actually go in and take out that gallbladder. For nursing interventions, you will drop an NG tube. There are several drains post-op, and you can actually see pictures of this in your book on 791. So there's several different drains that they might use. One is a T-tube, and it may be inserted into the common bile duct to drain that bile while that surgical incision heals. A Penrose is a kind of wider, flatter, rubber band looking. And JB drain, I'm sure you've seen those before. It's a vacuum drain with a bulb. You compress it and then it sucks out the blood or excess serosanguine fluid, whatever that might be. The Penrose and the vacuum inserted as well to suck out that serosanguine fluid from the wound. And then we record the drains, all keep real strict I's and O's. We're going to be monitoring pain control and then monitoring those dressings and those incisions as well. With pancreatitis, you will see that it is an inflammation of the pancreas. It may be acute or chronic. Typically what happens is there is a reflux of that bile and the duodenal contents into the pancreatic duct, causing autodigestion by the organ's own enzymes. So basically this pancreas is not able to flow the way that it needs to. There is a reflux, a backup of all these pancreatic enzymes, and these enzymes are what we use to break down our foods. And so instead of breaking down the foods because they can't get into the intestine like they should, they start eating away at the pancreas. The opening of the duct will swell. It will impair or obstruct the release of bicarb, which is used to neutralize chyme, which is that kind of the broken down food substance. As it enters into the small intestine, it obstructs the enzymes that digest proteins, carbs, fats, and therefore it starts eating at the pancreas instead of the food. So you can see right here an inflamed pancreas. Chronic pancreatitis is most commonly associated with excessive alcohol consumption. Acute has many various causes. So when you have acute pancreatitis, it could be anything from mild to severe. It can even be fatal. And when mild, the patient will be very, very ill, but function usually is going to return to normal within 6 months. If severe cases, the tissue will become necrotic and the patient will develop many complications. There are some known causes of acute structural abnormalities, abdominal trauma, infections, metabolic disorders, hyperlipidemia, hypercalcemia, IBD, vascular abnormalities, ingestion of alcohol or certain drugs. It could be hereditary, it could be feeding after prolonged fasting or anorexia. All of a sudden your body doesn't really know what to do with all that food or how to break it down, and it breaks down the pancreas instead. And then there's other unknown causes that we just don't know about. Here you'll see Cullen's sign and Turner's sign. Let me go back real quick. Sorry. Okay. And basically you can just see this bluish discoloration. It's indicating that the pancreas is bleeding. So it might be across the abdomen, it might be on the side. Other signs and symptoms include very ill with dull pain, tenderness, rigidity, epigastric pain that radiates to both sides and the back, so you have severe, severe back pain, possible low-grade fever, nausea, vomiting, steatorrhea or fatty stools, and anytime you see that word steatorrhea, you know that they're also frothy, foul-smelling, and it's all from poor fat absorption. This patient might be hypotensive, tachycardic, shallow respirations. They'll have large amounts of protein-rich fluid released into the tissues and the peritoneum, and it can lead to signs of shock and hypotension. So you can see hypotension, tachycardic. The colon sign, like I said, that one is right here across the umbilicus, and then the Turner side is going to be on the flank, so more on the side, but it is that bluish discoloration showing that the pancreas is bleeding. Symptoms are usually worse after fatty foods or alcohol consumption, and they're typically relieved by sitting in the fetal position or leaning forward. So oftentimes they'll come in and you'll see them just kind of hunched over or just hugging their knees in that fetal position. Diagnostics, we will do several labs, elevated serum and urine, amylase, lipase, and liver enzymes. The amylase and lipase are big indicators of pancreatitis because that's what the pancreas is excreting. It's excreting those amylase and lipase. Biliary obstruction is elevated bilirubin. We can do a CT and show inflammation of the pancreas. The treatment for acute will be pain relief. Pain is going to be a major issue. They're in so much pain with this. NPO, keep them NPO, nothing by mouth, no fluids. We will give IV fluids, TPN, to restore that nutrition that they're lacking because of the NPO. We will help drop an NG tube, albumin, bringing that that volume back into the vascular place because remember they are hypotensive, and then antibiotics treating that inflammation, that infection. For treatment of chronic, it's a little bit different. We will use pain control. We're not going to use morphine. Demerol is preferred because morphine will worsen the condition and cause more spasms, and morphine usually isn't really good with any kind of it's not the best pain control for any kind of GI issue. Well, of course we're going to cut out the alcohol. They will be on a clear liquid to bland free fat-free diet. They will need insulin, enzymes, and surgery. And of course, we've got to be compassionate. These people don't feel good and they are very scared. All right, and I think that takes care of it. Let's see.